Hi friends. So now we're beginning with the discussion of pediatric acute abdomen. This is one of the topics which is very frequently tested in the theory exam as short notes, wherein they will ask you either about acute abdomen in children, or they can ask you specifically about acute abdomen imaging in infants as well. So we are going to be talking about different ages and the different conditions. So both of those topics will be covered in the same lecture. Apart from this, these are frequently given as short cases or spotters. This is a very, very important topic as far as spotters are concerned, So images from CHPS, intussusception, we'll be talking about necrotizing enterocolitis. All of these are standalone important topics for the exam as well, right? So this is a very, very important talk that we're going to have here forth. So let's begin then. The first thing is clinical features. So what are the clinical features with which these children are going to present to you for having these different abdominal emergencies? So obviously, because it's children, there are going to be non-specific features which in infancy are basically going to be your only signs in the early stages, and these signs could be as subtle as non-stop crying, children who are crying a lot, So obviously an infant is not going to come and tell you that I am having right iliac fossa pain. The child is not going to tell you that. The child is just going to cry a lot, and you have to now rule out what is going on in the body, right? So one non-specific feature which is pretty common in the early stages is going to be crying, which is either increased or is incessant, right? So this is something which is important, that incessant crying is one of the early features. Apart from that, they can also present with poor feeding, which can again tell you that something is going on probably with the abdomen or the GI tract, right? So these are non-specific findings frequently in infants. Now, when we talk about the localization as far as whether it's upper GI tract or lower GI tract, what are the clinical features which will help you narrow that down? So, low obstruction basically means obstruction which is lower down in the GI tract. This is frequently going to present with symptoms of constipation, whereas high obstruction, that is higher in the GI tract, is frequently going to produce vomiting, right? So this could be bilious or non-bilious depending on whether it's proximal to the D2 part or it's distal to the D2 part. So obviously something which is proximal to D2 is going to be non-bilious vomiting, something like CHPS, something which is distal like duodenal atresia, ileal atresia, midgut volvulus, is all going to have bilious vomiting, right? So I'm just going to write here vomiting, bilious versus non-bilious is also going to help you narrow down the differentials here. Apart from that, something common to both of these is going to be abdominal distension, right? So this is when we're talking about an obstructive pathology. So most of the conditions we're going to discuss are going to be obstructive pathology. So this is the broad outline as far as that is concerned. Now, just to correlate here itself, even though it's not a clinical symptom, but when we look at the abdominal X-ray, how do I know whether it's high obstruction or low obstruction? It's going to be on the number of bowel loops that I'm seeing. So if you see, it's considered to be that if you see more than 3 air fluid levels or more than 3 dilated bowel loops, that suggests that the obstruction is lower down, right? So just to correlate here itself, this is going to be more than 3 bowel loops which are dilated, and high obstruction is going to be less than 3 bowel loops which are dilated. And as per the definition, what is the cutoff point at which I'm saying that proximal to it is high and distal to it is low is considered to be ileum, right? So anything proximal to the ileum is considered to be high obstruction. Anything distal to the ileum is considered to be a low obstruction, right? So this is how we are broadly going to categorize the pathologies that we're going to discuss. Also considering differentials on the basis of age. So if you have a preterm baby, particularly if they give you history like low birth weight, if they tell you that the baby is formula fed, you start thinking on the lines of necrotizing enterocolitis. If it's a newborn, right, then if the symptoms are obstructive, you start considering conditions like atresia. So it could be duodenal atresia, it could be ileal atresia, jejunal atresia, colonic atresia, which is particularly rare, but we are now considering recanalization abnormalities like atresia, something which will produce symptoms in infancy in general. Things like CHPS typically produces symptoms 1.5 months, 6 to 8 weeks of life is when it's gonna produce symptoms. Apart from that, you can have midgut volvulus, which can present essentially at any age, at any age in childhood it can present, but more common in infancy. Again, Hirschsprung disease is going to present around 48 hours of life. So newborn, but it can be a later presentation as well, depending on the severity. So that's Hirschsprung disease for you. And then you have intussusception. Again, intussusception frequently presents around 6 to 8 months. So these are frequently seen around infancy, right? So this is how the age group also helps you narrow down your differential diagnosis. So this is as far as the clinical scenario is concerned. Now let's get down to the imaging modalities. So whenever you are going to write a short note on this topic, this is what you want to start off with, that what is the role of different imaging modalities. The outlines that you see in this chapter are the outlines that you take for your theory paper, right? So you're going to start off with clinical scenario, you're going to write a few points on the different imaging modalities that I'm about to tell you, and then we go pathology wise, all right? So that's how you also have to take notes simultaneously. So now quickly talking about the different modalities that we have up our sleeve. So as you know, we are in the pediatric population, so we have to consider radiation dosage saving, right? We have to take into consideration guidelines which are talking about imaging gently. So we have to take into account modalities like radiography, contrast studies, CT scan, nuclear medicine scans. We have to avoid them as far as possible and justify and optimize their usage. That is something which is very, very important. So now when we talk about X-ray, this is something which is one of the most frequently ordered initial investigations, particularly when we're dealing with an obstructive scenario, as we just discussed, because this is where you will localize your pathology to a low obstruction vis-a-vis a high obstruction. So radiography is something which is definitely going to be important for obstruction cases. It is something which is very, very important for ruling out free air or perforation. This is something which we have to do when we are suspecting perforation peritonitis in the child. And one more very important thing is when you're suspecting a foreign body in a child, radiography becomes imperative. So this is something which is very important. Talking about contrast studies, which contrast? First of all, would you do a barium study in a child? Answer is no. You will not favor a barium study. We would favor a water-soluble contrast. So one thing, water-soluble contrast agents are preferred here, right? So we would tend to prefer either gastrographin or iohexol in children, because even if perforation occurs, we won't have the risk of peritonitis. There is fewer risk of electrolyte imbalance. So these are the 2 points. Lower risk of peritonitis, electrolyte imbalance is less common. That's why water-soluble contrast studies are preferred. 2 of the most frequent uses of contrast study. One is going to be midgut volvulus. Whenever you have a case of midgut volvulus, it becomes very important to know where the DJ flexure is placed, and a contrast, upper GI contrast study is one of the best studies that is going to show us the position of the DJ flexure. We'll talk about this when we go to volvulus, but for now, remember, it has a very important role, upper GI contrast study in midgut volvulus. And the second one, where a contrast enema becomes very, very useful, is Hirschsprung disease, right? So now we talk about Hirschsprung disease, wherein again a contrast enema becomes very, very useful. In fact, you can see here, this is a contrast enema which is showing you the narrow rectum and the dilated sigmoid colon, which is telling you about the diagnosis of Hirschsprung disease. In addition, whenever we are suspecting microcolon, so the different differential diagnosis of microcolon also I'll be discussing. So this is something, these are the 2 places or the 3 places where contrast study becomes very, very important. Now talking about ultrasound. So any society guidelines you take as far as children and acute abdomen is concerned, whether it's AAP guidelines or ACS guidelines, they recommend ultrasound as the first line investigation of choice for evaluation of acute abdomen. So remember, this is investigation of choice for evaluation of acute abdomen in children, hands down. Why? Because there is No radiation. Most important factor, there is no radiation. It is easily and readily available. It's a dynamic investigation. You know your kids are not going to stay still for a long time. This is something which ultrasound can take into account. So this is dynamic evaluation is possible here. So all of these are the advantages. It's portable. You guys know it. So ultrasound is the investigation of choice, particularly useful in cases of intussusception. Like you can see here in this image, you see the target appearance of bowel within bowel. So intussusception, it is the investigation of choice for CHPS. Volvulus as well, we can actually get an idea about the whirlpool sign of the vessel. So all of these we'll be talking about, but ultrasound remains very, very important as the first line investigation. The role of CT scan is more for a problem solving tool. If your ultrasound, your X-ray is not doing the job for you, we have to go for a CT scan, right? So again, when we go to CT, we want to make sure that we reduce the radiation by various measures that, I'll be talking about in a separate lecture, but we want to save radiation as far as possible. So CT, remember, is used as a more or less problem solving tool when we are in a diagnostic dilemma with the ultrasound or the X-ray. So here in a CT scan, you can see how there is swirling. There is a whirlpool sign which is showing you a case of midgut volvulus. There is whirling of the mesentery that you can see here. Same job is done by the MRI, but MRI, remember, in infants has a very little role because it is going to take a lot of time. We don't have time. It's an emergency. Plus, we would need additional anesthesia in children for them to remain still, particularly in infants. So, MRI is not something that we would prefer a lot. Nuclear medicine has niche role, like this particular condition that I'm showing here, which is a Meckel's diverticulum, right? So, this is particularly the study that is technetium 99M per technate, which is the best investigation for evaluation of a Meckel's diverticulum that's presenting as a lower GI bleed. So there is where nuclear medicine comes into play. It also has role in diagnosing torsion, right? It can also help us with the diagnosis of duplication cysts. So these are the three niche indications for a technetium scan here, right? So this is your short note on the different imaging modalities that would be used in acute pediatric abdomen. Now, just a quick word on the pediatric protocols that in general we want to employ. So you guys know about the Alliance study, right? So this is the Alliance study which talked about image gently, and now this has been expanded. This is also an important Viva question. So image gently, step lightly, meaning you step lightly on the fluoroscopy paddle, right? We want to save as much radiation as possible. So image gently, step lightly is the Alliance 2007 guidelines. We also have the choosing wisely guidelines. So you can just remember this for your Viva. These would be questions that which will be these will be questions which will be asked to you if your Viva is going really well, right? So image gently, choose wisely. Apart from that, we have the ALARA principle. So ALARA principle talks about as low as reasonably achievable, right? So this is again something. So this is a short note in itself. Pediatric dose optimization is a question in itself. You want to take minimum views. So these are the bullet points you want to keep in mind. ALARA. Then you want to take minimal views. Use gonadal shield in X-rays all the time. You have to use lower radiation dose protocols. So nowadays in CT, again something very important for your Vivas is AEC, automatic exposure control. So in a lot of machines, they have their different names depending on the brand, but it is something which is like in most of the machines it will be as CARE 4D. So this is where the machines are gonna use automatic exposure control depending on the patient size, and this is very important for saving the radiation dose here. So this is about AEC. And finally, optimization and justification is one of the most important principles for ALARA, that you decide wisely which investigation is best and you try to save radiation to the maximum possible manner, right? So this is what is about the imaging protocols. Now going on to the core topic here. So we are going to be talking about all of the conditions in a case-wise scenario here. So I'm going to give you the clinical scenario and then we discuss the imaging one after the other. We discuss the diagnosis and the management. So that's how this class is going to flow. We have around 10 scenarios. So 10 different conditions, one by one we'll be studying in an integrated fashion. So when they give you history of a preterm baby, artificial feed, particularly a low birth weight baby, presented with vomiting, bloody stools, lethargy, and incessant cry, clinically you start obviously thinking in the lines of necrotizing enterocolitis. Two main workhorses as far as investigations are concerned here are going to be X-ray and ultrasound. So in early cases on X-ray, what you're going to see is bowel dilatation, right? So if you look at this X-ray, you can see diffuse dilatation of the bowel tubes. As the days proceed, so most of the times, you will be given serial X-rays of the baby here. Initially, there's bowel dilatation. Then you start to see this granulated sort of an appearance, right? So this is something that a lot of times in normal children, you'll also see in a granulated fecal matter appearance. But in this case, if you look carefully, you can see how there is air which is entrapped in the bowel wall. Very beautifully seen here. I'm going to zoom this image so that you can see how there is this lamellated density here, which is the air which is entrapped in the bowel wall, which is nothing but pneumatosis intestinalis. So when the air is trapped in the bowel wall, this is an ominous sign which tells you that now the translocation, the bacterial translocation is happening and there is impending perforation of the bowel wall, right? So pneumatosis intestinalis is definitely an ominous sign here. And in addition, something that clinches the diagnosis, if this comes as a spotter, is portal venous gas. So this is portal venous gas, which is one stage ahead of pneumatosis there. And finally, if you did not make the diagnosis in time, what is going to happen is there's going to be perforation. So in this case, you can see how there is free air. Obviously, in a child, you're not going to get erect X-rays, you're going to get supine X-rays. So you can see how there is air encircling the entire bowel, which is called as the football sign. And one more tip that you can actually use to diagnose air more sensitively before waiting for football sign is this cross table view. So a lot of times in children, we can take these cross table views with the child remaining supine and you can see this air anteriorly more sensitively, right? So this is where X-ray comes in. So what you're going to see is bowel dilatation in early cases. After that, you're going to see air in the wall, which is called as pneumatosis intestinalis, and you're going to see portal venous gas. In later stages, we're going to see perforation as pneumoperitoneum. On supine X-rays, what we're going to get is a football sign. And what is better for picking up pneumoperitoneum is a cross-table view. These are all the points that we need to keep in mind as far as X-rays is concerned. Then talking about ultrasound. So ultrasound again is going to show you this intramural air. So this is pneumatosis, which is showing you this entrapped air. So ultrasound has the advantage that pneumatosis can be differentiated from intraluminal air. How do you distinguish pneumatosis from intraluminal air? So remember, pneumatosis is not gonna move. This is gonna be air which is not moving on dynamic maneuvers, change in position of the baby. This is not moving on compression by the probe, right? So this is something which is a fixed air that you are seeing. So this is how you can actually diagnose pneumatosis. And finally, what you see here in the liver is portal venous gas. So ultrasound is a very good investigation for necrotizing enterocolitis here. Okay. So just to integrate the pediatrics with you, you should know about the modified Bell staging. If your Viva is going well, they'll definitely get to this. So modified Bell staging is what is used for necrotizing enterocolitis. It has 3 stages, 1, 2 and 3, which are further subdivided into A and B. So 1A is mainly clinical, wherein you start to have bradycardia, apnea, temperature instability. You can remember this as BAT, right? So bradycardia, apnea, temperature instability. The management remains conservative with NPO and antibiotics for 3 days. 1B, B for bloody stools, right? So 1B, you start to have bloody stools. Going to stage 2 is when the radiological signs start to appear. So you start to have dilatation and pneumatosis in stage 2A, and 2B is portal venous gas in addition to acidosis and thrombocytopenia. So again, conservative management at this point, but you can now remember radiological signs are evolving. What is 3A is, again, you can remember bad. From bad, we've gone on to bad because again, our patient is going on to bad. So you have bradycardia, you have apnea and acidosis, and you have DIC in addition. So you have DIC, which has now developed 3 letters in DIC. Stage 3 is how you can remember. Again, at this point, we are doing conservative management, but your patient becomes a surgical candidate the moment there is perforation. So final stage is free air, which is pneumoperitoneum, right? So these are the different stages of modified Bell staging of NEC that we need to be aware of. So this is about NEC. Let's go to the next scenario. So now we are going on to the highest level of obstruction at the level of stomach. So because it's at the level of stomach, what kind of symptoms do we expect? Non-bilious vomiting. So here you're going to get history that a child is having these projectile episodes of vomiting every 1.5 hours after feeding, because of which the child is emaciated, there's weight loss, and it's persistently hungry. And one more additional clinical finding that you would be able to see is every time the mother feeds the child, the mother observes that there is this olive-shaped mass, right? So there is this olive-shaped mass which can be appreciated, and in addition, you can also observe these visible waves of peristalsis from left to right. So left to right waves of peristalsis can also be observed here. So this is something which is very, very typical for a diagnosis of congenital hypertrophic pyloric stenosis. So as the name suggests, what you're gonna have is hypertrophied pyloric muscle. The pyloric muscle is hypertrophied. This presentation is frequently around 6 to 8 weeks after birth. Males are more commonly affected. So there's a condition wherein males are more commonly affected, and there is some association with maternal intake of erythromycin. So these are just few facts which we want to know. So maternal intake of erythromycin is implicated with CHPS. Coming to the imaging now, so what you're going to see, because the obstruction is at the level of stomach, we see this hugely dilated stomach bubble, also called as a single bubble sign. This can further be seen better if you inject some air from the NG tube. So a maneuver that you can actually do is you can inject some air from the NG tube and you would see it better, like in this case. So this is a single bubble sign. What is the best investigation? So the workhorse here is going to be ultrasound. What you want to remember on ultrasound, again, how to visualize it better is going to be a few dynamic maneuvers. So what you can do is you can place the baby in a RPO position. So right side down will basically bring the pylorus up here, or you can visualize in a prone position. So this is one thing which is very important. Apart from that, you can also inject some water from the NG tube, and that will distend the stomach. Like in this case, the stomach is distended so that the pylorus is better visualized. There are criteria to diagnose CHPS. So here there are 3 numbers that you need to remember. So if you take the transverse diameter of a single-sided muscle, that has to be more than 3 millimeter. If you take the total transverse diameter into account, that has to be more than 14 millimeter. And if you take into account the length of the pyloric canal, that has to be more than 15 millimeters. So these are 3 numbers that you can remember: 3, 14 and 15. So I'm just going to label these A, B and C so that we can correlate with the numbers here, right? So these are 3 measurements on ultrasound which is pretty diagnostic of CHPS. the role of barium meal is only theoretical. Once we have done the X-ray and the ultrasound, this is something which is not really needed to make a diagnosis, right? So this is something which is predominantly theoretical. What are the different signs on a barium meal? So you're going to see this narrowing here, which has been likened to a string. Okay, so this has been called as the string sign. A lot of times you will see two tracks, which is known as a double track sign. You can see this duodenum here, which is a mushroom sign. There's also these tracking of the contrast known as diamond sign. You can see the shouldering of the proximal stomach, so shoulder sign, beak sign, and the slow movement of the barium here has been called as the caterpillar sign. So variety of signs, not really very useful in real life. So this is what you need to know about CHPS. Apart from that, how do you manage? So this is something where medical management is actually more urgent than the surgical management. So most of these babies are gonna actually come to you in a dehydrated state. They're gonna come to the emergency with electrolyte imbalances. This is one of the very important questions. What kind of electrolyte imbalance these babies come with? Not very important for us as radiology practitioners, but you need to be aware of this, right? So what are the different electrolyte imbalances? So you are gonna have one low BP / dehydrated baby because of the persistent vomiting with hypochloremic, hyponatremic, metabolic alkalosis, right? The child is losing a lot of acid from the stomach. So there's going to be metabolic alkalosis, and because of the renin-angiotensin pathway, what you're going to also have is paradoxical aciduria. A lot of H plus gets excreted in the urine as well because of aldosterone. So this is the kind of electrolyte presentation that you're gonna get. So you have to supplement this child with a lot of fluids before you take them up for diagnostic investigations or for surgery. And the definitive management, if they ask you, is gonna be a Ramsted's pyloromyotomy. So what is to be done is they cut the pyloric muscles here. Another new investigation here is a Poems procedure, something you would have read for achalasia cardia, right? So this is something which is a per-oral endoscopic myotomy. So this is something which is an endoscopic procedure through the natural orifice. So this is something which is a recent advance. So this is about CHPS as a whole. Now let's talk about the third case scenario. So now we have a newborn who's presented to us with bilious vomiting, abdominal distension, incessant cry. So when we look at the X-ray, there are two bubbles, two dilated bubble loops, meaning we are dealing with a case of high obstruction here. And directly when you see this image, two distended bubbles of stomach and proximal duodenum, this is something which is a spotter, right? You get this as a spotter. This is known as the double bubble sign of duodenal atresia, right? So this is where there is a problem with recanalization of the duodenum. This frequently happens in the late first trimester. So this is nowadays a diagnosis that is not actually made in newborns, but it's actually made antenatally on the antenatal ultrasound. So I'm showing you the antenatal ultrasound as well, which is again going to show you beautifully the two bubbles, the two dilated bubble loops here. And in addition, you will also see that there's a lot of fluid because the child is not able to swallow. The liquor here is going to be more, so there is going to be polyhydramnios with the double bubble sign, and this is something that you would pick up on the antenatal ultrasound frequently, right? Having said that, if you see the double bubble sign, apart from duodenal atresia, there are other differentials that you have to consider. One is annular pancreas. This is not something that usually presents in a neonate. This is something which usually presents in adults with not so acute presentation. So they can have subacute vomiting, subacute obstruction. That is how these patients present, but it's one of the differentials of a double bubble sign. And then there are LAD bands, which we will be talking about in malrotation, which can also cause duodenal obstruction at this level. So this is something which is associated with malrotation, and something which, if your viva is going great and you answer this, you are going to top the exam. So the anomaly that I'm talking about here is an anomaly of the portal vein. So the anomaly is a pre-duodenal portal vein. So this is an anatomical variant which is thought to be a persistence of the left vital line vein. So this is a remnant of the left vital line vein, and this is frequently associated with heterotaxy syndromes, right? So where you have situs issues, that is where you're going to see this variant wherein a portal vein courses anterior to the duodenum and ends up obstructing it. So these are the 4 differentials for a double bubble sign. Obviously, the first you have to rule out is duodenal atresia, but others could be annular pancreas, Ladban's, and pre-duodenal portal vein. All right, so this is what you have to know about duodenal atresia. Going on further distally, so when you have a newborn with a similar symptom, but now on the X-ray you're seeing more air fluid levels, either you are seeing 3, which is known as a triple bubble sign, or you are seeing even more air bubbles, more than 3 air bubbles, which tells you that probably it's ileal atresia or maybe even more distal to the ileum, right? So this is what we have, which is jejuno-ileal atresia. What you're actually gonna see if you end up doing a contrast enema here is a microcolon. Why? Because the colon hasn't been used. There is atresia at the level of jejunum ileum. The colon has not had any fecal matter. It has not had to do any work. So it's gonna be microcolon on a contrast enema. So this is one of the differentials for microcolon that you want to remember now. Also important for the theory aspect is the different types of jejunal atresia or ileal atresia. So there are 4 types here. So the type 1 is where you just have an intraluminal diaphragm. So you just have an intraluminal diaphragm here, which is causing a level of obstruction. In type 2, what you have is this cord-like segment. In between 2 loops of bowel, you have this cord-like segment is the level where you have the obstruction. In type 3A, you have a V-shaped defect. So this is a V-shaped defect wherein it's not just the bowel but also the mesentery. So you can also see that there is in addition a mesenteric defect here. And type 3B, something that is a favorite of examiners here, is also known as the apple peel deformity, right? So this is the apple peel deformity wherein you have multiple segments. You can see how there are multiple segments of narrowing, and you have the distal ileum which is coiling around the ileocolic artery. So there is this ileocolic artery around which the distal bowel is coiled, and 4 is where multiple segments are basically having atresia. So these are the different stages. So diaphragm, then you have a cord-like narrowing, V-shaped defect, apple peel, and multiple segments, right? So this is what is about jejuno-ileal atresia. So quick recap, so far what all have we discussed? Case scenario number 1, we talked about NEC, right? Case scenario number 2, stomach level CHPS. Then we talked about duodenal atresia, and now we are on to jejuno-ileal atresia. Let's talk about the next scenario. So now we have a 4-week-old boy with bilious vomiting, abdominal distension. So I'm localizing somewhere around distal to the duodenum, but because the X-ray is not showing a lot of air bubbles, it's a high obstruction again, right? So now what do we have? We have a single bubble here, but then you can also see that air has passed distally. Unlike what we saw with the single bubble of CHPS, let me just run back there and show it to you. There is no distal air here. There is no air in rectum. There is just the stomach bubble here. But in this case, even though stomach is dilated, but air has passed distally. In fact, it has reached up to the rectum also. You can also see the gonadal shield here, right? So it has passed distally, meaning it's not a complete obstruction. There is obstruction for sure, but it's not something wherein the obstruction is complete at the level of pylorus. So that's what I get from the X-ray. What we are getting here in the upper contrast study is what is the most important. So what you're seeing here is this is the esophagus, this is the stomach. Now when I start to look at the duodenum and the DJ flexure, normally the DJ flexure has to cross on the left side. It has to cross on the left of the midline, and it lies at the same level as the pylorus. So this is what is very, very important from anatomy point of view, that this is the transpyloric plane where you have the D1, and this is the same plane where we expect to see the normal DJ flexure on the left side of midline. If it doesn't cross the midline, it is on the midline, and then I start to see this twisting here, what does it tell me? It tells me that there is malrotation, and because of that now there is this twisting of the bowel on its own axis, which is known as volvulus. So this is diagnostic of midgut volvulus. This is what we call as the corkscrew appearance. So corkscrew sign is what is seen here. It tells you about malrotation because the DJ flexure is not crossing the midline, right? So what I'm seeing is that the DJ flexure here is not crossing midline, and what I get here is a midgut volvulus. So what happens in midgut volvulus? The mesentery is twisting upon its own axis. Why and how? We'll discuss the entire pathophysiology with embryology. But for now, remember there is twisting. So what's going to happen when you look at the ultrasound and the CT? Again, you see this twisting of the vessels. You see this whirlpool sign. So both the CT and the Doppler here are beautifully showing you how these vessels are going round and round like a whirlpool. Again, for malrotation, what you're going to see is the altered relation between SMA and SMV. Normally, where does the SMA lie? So you want to remember small here. Normally, SMA lies to the left of SMV. SMV is on the right, SMA is on the left. So you can remember a trick, small. If you see that this relationship is altered, this is a sign of malrotation. So this is one, and then when you have volvulus, you're going to start seeing this round and round whirlpooling of the vessels. Also, if you look at this CT closely, you can also observe how all of the small bowel loops are on the right side and all of the Haustrae and the large bowel loops are on the left side, which is again telling you that there is malrotation which is happening here. So this is basically midgut volvulus, which frequently has malrotation as a risk factor. So any case of midgut volvulus you encounter, you must rule out malrotation. How this is managed is basically why malrotation is happening. It's because of the lack of the anti-clockwise 270-degree rotation that was supposed to happen. So now what we got to do is this detorsion here. In addition, there are LAD bands that need to be removed. And prophylactically, the surgeon are also going to do an appendicectomy here. So this appendicectomy is done because this appendix is going to be variable in position. So further down in life, we don't really want this diagnostic dilemma. So they remove the appendix prophylactically. So this is the surgical management of midgut volvulus. Now let's go back in time and understand why this happens. So a brief talk on GI embryology and why malrotation happens and what are the different types of malrotation, which could be an independent question in itself. Okay. So around 6 weeks of life, so between 6 to 12 weeks of our intrauterine life, what is going to happen is this physiological herniation of the bowel. I'm sure you've all heard about this and read about this way back in your first year, right? So what happens is that at 6 weeks, you have the physiological herniation of the bowel, and who is the guide? It is SMA. So around the SMA, superior mesenteric artery, we have the bowel which is coming out. Now, how I want you to understand this is, imagine the upper part of this limb as the proximal bowel, or let's name it DJ. So this is our reference for the DJ flexure or the small intestine. The below limb, let's mark the prototype here as IC junction or the large bowel. So superior part is DJ, inferior part is IC junction. So now if I'm looking at it from end on, if I'm looking at it from here, can I just say that DJ flexure is here and IC junction is here? Yeah. What happens from 6 to 12 weeks is, first this undergoes 90-degree anti-clockwise rotation, and after that it goes further 180-degree anti-clockwise rotation to reach the eventual stage, and then it comes in. So in total, what is going to happen is 270-degree anti-clockwise rotation, right? So now what happens to this when we look at it in terms of this clock hours? So DJ initially was here. I am saying that it undergoes 270-degree anti-clockwise rotation. So do you all agree that the eventual position of DJ is here? Yeah. What about the IC junction? It was initially here and it undergoes 270-degree anti-clockwise rotation. So it's going to end up somewhere here. But because the cecum undergoes growth, it lies somewhere below the midline, and this is where it reaches this tiny thing being appendix. So this is where I have the IC. And this is how our normal bowel looks like. So this is normal rotation. Did you understand? So eventually what happened? DJ flexure to the left of the midline. Remember how I was talking about this? DJ flexure lies to the left of the midline, whereas IC junction is to the right of the midline, somewhere in the right iliac fossa. And between them what lives? Between them what is lying here is the mesentery root. So this is where we have the root of mesentery, and then the mesentery is hanging like a ballerina skirt from this level. So this is how our normal rotation is happening. Now, when I look at a normal barium study, this is what I have to ensure. So normal rotation. How do I rule out malrotation on barium? So this is what normal rotation looks like, wherein this is the DJ flexure, right? So this is the stomach and these are the three parts of duodenum. This is the DJ flexure. So the normal DJ flexure, very, very important, should be one on the left of midline. Second, it should be placed at the same level of L1, which is the transpyloric plane where the pylorus lies, and it's the same plane as the duodenal bulb, which is D1. So all of these should be in the same plane. And if you do take a lateral view, this should be in the retroperitoneum. This is something which is lying posteriorly. All right. So this is what ensures, once you see these three criteria being met for DJ flexure, it's a criteria for normal bowel rotation. Okay. So this is what we now understand as normal rotation. Now let's understand what happens in abnormal rotation, or let's talk about rotational abnormalities. First thing we have to consider here is non-rotation. So what happens in non-rotation is that only this 90-degree, first 90-degree anti-clockwise rotation happens. Rest of it doesn't happen. So now let's go back to this picture here and understand how this will translate. So now if this is what we are having, what is going to happen here is this is how we started, DJ flexure and IC junction. If there is just 90-degree anti-clockwise movement happening, do you agree that this is where I have DJ and this is where I have IC? In short, my entire small bowel is now on the right side and my entire large bowel is on the left side, isn't it? So this is what you're going to observe. Small bowel completely on the right, large bowel completely on the left. Remember me telling you about this on the CT? All small bowels on the right, all large bowel on the left, whereas this is not what I wanted to see in a normal case. So this is one thing. Apart from that, why does volvulus happen here? So now imagine what will happen to the mesentery. The mesentery is arranged very, very horizontally here. So if this is the root of mesentery, my entire mesentery is hanging down in the same plane. So this is why there is very high risk that there's going to be twisting and there's going to be volvulus. Okay. I hope the concept here is clear. So what happens in non-rotation? You have all small bowel on the right side. You have all large bowel on the left side. So this is what you can also observe in this barium study. Small bowel loops on the right, these striations and the colonic loops on the left side. So this is non-rotation. Then we can also have reverse rotation. What happens in reverse rotation? So normally when the bowel is coming back, remember L and L. The large bowel is last to come in. The small bowel comes in first and large bowel comes in later. But if this is reversed, if large bowel comes in first, it comes in before small bowel, what you're gonna see is that the duodenum is now anterior to the transverse colon. So here what is the marker is that the duodenum is anterior to transverse colon, and what that's going to result in is colonic obstruction. It's going to obstruct the transverse colon. So this is where you have reverse rotation, and finally you can have mixed rotations. It's somewhere in between, so this is known as mixed rotation, also known as incomplete rotation. And one finding you want to remember here is a subpyloric cecum. The cecum is higher up and it assumes a position below the pylorus, and this is where you have these LAD bands that we've been talking about coming in here. So these LAD bands are going to connect this duodenum. So this is where these LAD bands are connected from the cecum to the lateral abdominal wall, and in the process what they do is they block the second part of duodenum. So this is why you're gonna have a double bubble here, right? So now you're understanding these LAD bands. So they're gonna go from the cecum to the lateral abdominal wall, and in the process they obstruct the duodenum. So these are the different rotational abnormalities that I hope you've understood conceptually now. Okay, now let's go to the next case scenario, something that you would most likely see in your residency, at least once, if not more often. So here you have a child, 7 months old baby, very typical history after rotavirus vaccination, comes to you with bloody stools, vomiting, incessant crying. So if it was an MCQ, I think all of you would get it correct. The moment we hear rotavirus, this is intussusception, right? So what is intussusception? It is the telescoping of one part of the bowel into the other, right? So what happens here? This is a schematic showing it. So you have one part of the bowel which is going inside the other, and there are various causes, various hypotheses related to it. So one could be lymphoid tissue swelling. So somewhere around 6 to 8 months, because of either dietary factors, because weaning happens around this time, you give various vaccines like rota and poliovirus. What happens is the mesenteric lymph nodes swell up, and in addition, Peyer's patches, which are these mites, right? So these are mucosa associated lymph nodal tissues which are present in the distal ileum. They swell up, and this is what tends to act as a lead point. It acts as a point which is pulling this intestine inwards, and this is why it's frequently the ileum going inside the colon. So it's the ileocolic type, which is the most common type, and in around 10% cases you can also have a pathological lead point. You can have a lead point other than just the Peyer's patches. So pathological lead point could be a Meckel's diverticulum, it could be a polyp. In cases of Henoch-Schondlin purpura, also you can have submucosal hematomas which can act as a lead point. You can have a tumor here. So there are various pathological lead points which could be there. Alright, so now going back to the imaging, what you're going to see on X-ray is frequently a non-specific. So either you can have a gasless abdomen or you can have non-specific bowel loop dilatation. But a specific sign is this, wherein you beautifully see that there is one bowel loop inside the other bowel loop, and there is this air entrapped between the two, giving rise to this crescent sign. So this is known as a crescent sign, something which is specific but not very sensitive. Again, one of the most frequently used initial investigations here is going to be ultrasound, right? So what you're going to do the first, and something which is diagnostic, is ultrasound, wherein you're going to see that there are these two bowel loops here, one within the other, producing a sandwich of sorts. And you can also see the hyperechoic mesentery here. You see the hyperechoic mesentery here, which is telling you and differentiating the two bowel loops. So this is a transverse view. On a sagittal or a longitudinal plane, you're again going to see this appearance wherein you see these hyperechoic areas. A lot of times you can also see lymph nodes, mesenteric lymph nodes inside, right? So this is something which is very, very important. So there are various names. So this can be called as the target sign or the donut sign, also called as the sandwich sign. And this, particularly on the sagittal view, has been likened to a kidney. So hyperechoic medulla and hyperechoic cortex, it kind of looks like the kidney. So this is the pseudo kidney sign. If the diagnosis is made on ultrasound, now you proceed towards the treatment. So something which has been considered to be a very good treatment option is enema, right? So we have to do an enema which could be a barium enema or an air enema, right? So we have to do reduction, which could be pneumatic reduction or barium reduction, or sometimes we can use a saline reduction as well. So this has been called as the gold standard because this is diagnostic as well as therapeutic, right? So now we're talking about barium enema. So barium enema, what's going to happen is when I do a barium enema, I will see at the level of the intersusception, there is this claw or a pincer grasp or a meniscus which is forming. So this has been called as the claw sign, and this tells me the point where there is intersusception. And as we keep on pushing the barium here, what's going to happen is because of the hydrostatic pressure, it starts to reduce and you start seeing this coiled spring appearance, which is actually a sign that your enema or your reduction is working. So barium enema is not just diagnostic, it is therapeutic as well. Another option that we have, which is now considered to be better than barium enema, I'll show you a comparative table, but it's now considered to be better than barium enema, is pneumatic reduction or an air enema. Again under fluoroscopy guidance only, but now you're injecting air. So what you can see is this meniscus forming initially, and once it is reduced, you're gonna see that the air column is now going forwards, right? So this is air enema. So treatment here, remember, we have to first know when to do surgery. So obviously, if you are having a perforation or a free air, the peritonitis case, obviously you take the patient up for surgery. If you have signs of a necrotic bowel or you have any other danger signs, clinically surgical treatment is indicated. And if your enema is not basically resolving the intersusception, so if the enema is not working, again it becomes a surgical indication. If all of these are ruled out, the mainstay of treatment is going to be enema. So now, which enema? So now I'm going to show you a comparative table, again very important for theory exam as well. So we have a barium enema, we have air enema, and you can also do an ultrasound guided contrast enema or a hydrostatic enema here. Advantage of barium is that the perforation rates are lower and you can better visualize any lead point if any. Disadvantages are that there is higher X-ray exposure. It takes longer time, around 20 minutes. The success rate is relatively lower of around 80%. It requires more experience. There is barium peritonitis, which is, risked because we're injecting barium and you can only visualize intraluminal contents. The advantage with air enema is that it has a higher success rate. It also is much quicker and it requires less experience. But obviously the disadvantage is that because you're injecting air, the pressure can get higher and you can have higher perforation rate. Again, you only visualize intraluminal content with all fluoroscopy studies and lead point can be missed. The advantage with ultrasound is that you can visualize all the components, intra as well as extraluminal. It's a real-time investigation. There is no X-ray, but it can take longer and the success rate is pretty high and perforation rate is low, but it needs more skill and experience. This is just a comparative analysis. In practice, what we end up doing is a barium enema most of the times or an air enema, and this is your equipment for pneumatic reduction with air enema. The pressure that you have to generate. All right, going on to the next case. So now we have a 9-month-old baby who's presenting with abdominal distension, hematochezia and lethargy. So what you see on ultrasound here is this anechoic lesion with posterior acoustic enhancement, and what is remarkable here is that it has the gut signature, right? You see it in relation to the bowel, but what is the clincher here is that it is a gut signature positive. You see the different layers, the variegated appearance of the bowel, which is known as the gut signature, wherein you have alternating hypo and hyperechoic areas, which tell you that this is a cystic lesion which is related to the bowel, and that is diagnostic of a duplication cyst, right? So this is a duplication cyst frequently associated with the ileum On the CT scan, again, what you're going to see is a cyst here. You can have peripheral enhancement if there's secondary infection, but this is a cyst, and you see that it is related to the bowel. So that is how the CECT helps us. But the workhorse again is going to be ultrasound in this case. One very interesting case that you want to rule out here in this case, which will appear cystic but will have so many septations here, will not show you the gut signature, is a lymphangioma. So you can have intra-abdominal lymphatic malformations or lymphangiomas that you want to keep in mind, which will present as these hypodense lesions, multiple septations, but there is going to be no gut signature here. Alright, so this is about the cystic lesions. Now talking about older children, so something which frequently we'll see, in either middle-aged adults or in older children. We have an 8-year-old child with periumbilical pain, vomiting, mild fever. Start to think of acute appendicitis. So this is the clinical score, which I'm sure you're aware of, is the Alvarado score. So these are the different clinical manifestations that you give a score. Anything more than or equal to 6 means there's a high risk of it being appendicitis clinically. So Mantrels is the abbreviation. So migrating pain, wherein it starts periumbilically and then migrates to the right iliac fossa. You have anorexia, nausea, tenderness in right iliac fossa gets 2 points, rebound pain, fever, leukocytosis, and a left shift indicating acute sepsis are what are the clinical manifestations. So you just got to have an idea about this. Coming to the imaging manifestations, ultrasound obviously is something which is the first line investigation, but the problem here is that appendix is very dynamic in position, right? So it's very variable in position. So most commonly it is behind the cecum, but it can be variable. So it can be variable in you and I, and it can also be variable in me. So it can be different in position at different time points. So, right. So remember that the variability is not just between two people, but in one person also there can be different positions at different points of time. So that makes our job on ultrasound pretty difficult. So again, the most common site, because it is retrocecal, the cecum being filled with air or fecal matter is going to obscure your view of ultrasound. So ultrasound is great if it makes the diagnosis. It's very specific, but then it has less sensitivity. So it can be frequently equivocal or can miss the diagnosis altogether. But what are the typical manifestations is what we got to know. And this is something that in every night duty, you're going to get these cases. You're going to be diagnosing appendicitis a lot. So this is one of the things that you have to see early on. You have to learn early on, and then there's no looking back. So what you're going to see on ultrasound, what are the typical findings of acute appendicitis is going to be this anechoic blind ending tube that you have, which is not going to be compressible, which is not going to show you peristalsis, right? So what is very important for you to answer, and this is something which has to come out in one sentence from you, when the examiner will ask you this. So you are going to see a blind ending anechoic area with no peristalsis. So aperistaltic, non-compressible loop. There is going to be AP diameter, which is more than 6 millimeters. So it's a dilated tube that you're seeing. And a lot of times you're going to see this mural stratification. You're going to have fluid accumulating in the walls because of the inflammation. So there is going to be this mural stratification that you're seeing. A lot of times at the tip, we are also going to have an appendicolith, like in this case, which is going to show you posterior acoustic shadowing. So you can see an appendicolith. And if you do a Doppler, a power Doppler is being shown to you in this study, there is going to be increased flow, right? So there's going to be increased vascularity because of the inflammation. So when you see all of these findings, you are damn sure that you're dealing with a case of acute appendicitis. But it's not something that you will see in a lot of cases very, very easily. A lot of times, you will have a child pointing to you that this is where I have the pain. The moment you keep the probe, you'll see it. But you're not lucky in all cases like that. So what are different things that you can do? So one is known as a compression, or better known as a graded compression technique, wherein slowly you keep increasing the compression on the abdomen and you're shifting the overlying bowel loops from our appendix, right? So that's known as a compression, which is increasing in a graded manner. So graded compression. Another technique is a dynamic ultrasound. So this is again a very useful tip, wherein you start off imaging in a supine position, then you shift your patient into a 45-degree left posterior oblique. You put the left side of the patient down, image the patient, and then again shift the patient to supine. So this is going to increase the detection rate. There's one study which said that the detection rate increases from 30%, which is around 1/3, to around 60%, which is somewhere around 2/3. So you get a massive increase, almost twofold increase by doing this very small maneuver that you can do in a minute, right? So keep the patient in a left posterior oblique position for around a minute, keep the patient back to supine, and your chances to pick up that appendix increases for sure. If it is an equivocal diagnosis or you're not sure, the investigation of choice here becomes a CCT, because obviously cross-sectional, so higher sensitivity. You will pick up this blind ending appendix which is showing inflammation. It is dilated to more than 6 mm, sometimes it can be as dilated as 12 to 14 mm as well. So you see this dilated appendix here. You can also see some sort of cecum enhancement, which is known as a cecum or a cecal bar sign or an arrowhead sign. So you can also see enhancement and thickening of the base of the cecum in a lot of cases of appendix. You can also see the appendicoliths in a lot of cases. Sometimes you might not see the appendix, but you will see this collection here. So you can see this heterogeneously enhancing collection with a few air foci, which indicates a local perforation of the appendix with associated phlegmon formation. So you can also see this phlegmon here. So this is what you need to know about the imaging of appendix. Another mimic of appendix, exactly similar clinical manifestations. On the ultrasound also, sometimes, it will mimic an appendix. But when you look at the CT here, what you will see is this blind ending pouch here, which is actually somewhere close to the distal ileum. It is not exactly attached to the cecum, somewhere close to the distal ileum. And now what we are dealing with is a case of Meckel's diverticulitis. So this is one of the closest mimics of appendicitis that we encounter on imaging, and in a lot of cases you will give the diagnosis of appendix, but the surgeon will go in and find the appendix to be completely normal, and later on we'll discover that is actually Meckel's diverticulum, right? So what is a Meckel's diverticulum? I'm sure you all know it. It's one of the remnants of the vitalointestinal duct. You know the rule of 2 for Meckel's diverticulum. So this is something which is seen in 2% population. It is frequently 2 inches in size. The most common location is 2 feet from the IC junction, and it has 2 kinds of mucosa. So it has gastric mucosa and pancreatic mucosa. So it can be inflamed, resulting in Meckel's diverticulum. It can act as a lead point and present as intussusception, or the gastric mucosa can ulcerate and it can actually present as lower GI bleed, which is painless. So it can also present as this typical red currant jelly stool, which suggests lower GI bleed, in which case our investigation of choice becomes a technetium 99M per technate scan. So this is a compound which has a tendency to bind to the gastric mucosa. So you can see how it's binding to the normal stomach, and then it picks up the gastric mucosa of the Meckel's and presents as a hotspot, right? So this is how the Meckel's diverticulum can present as different clinical scenarios. Now talking about low obstruction. So if you have a 3-day-old baby who has not yet passed meconium, one of the biggest differentials that we have to consider is Hirschsprung disease, right? So now let's talk about Hirschsprung disease. What happens here is that the neural crest cells, which are going to make up the enteric plexus, the enteric ganglia that gives them the property for peristalsis, they do not migrate. So the pathophysiology here is that the neural crest cells have failed to migrate to the distal part of the colon. So the migration happens in a craniocaudal manner in the bowel. So what happens is that the distal part, the neural crest cells have not yet come, so there is no enteric plexus, and that is why there is basically no peristalsis that happens in the distalmost part. So it can be a short segment wherein only rectum is involved. It can be a long segment wherein you have rectum plus colon which is involved, and very rarely you can have total colonic aganglionosis, right, wherein the entire colon does not have ganglia, which is then going to present as microcolon that I will be talking about. The most common is obviously the short segment. So now let's discuss that. So what happens is, again, the workhorse here is going to be a contrast enema that you do. Normally, we are going to do this in a lateral position. So in a lateral position, you start inflating your contrast. You can put in a Foley's catheter. You can inflate the bulb as well, but make sure you're not over distending the bulb. Otherwise, you might misinterpret the results. So in a lateral position, we start insufflating. What you're going to see is this is the rectum, and now this is the sigmoid colon. So what you see is a transition zone here. Remember, normally rectum is the most distended part. It's the most distended part on a barium enema, and sigmoid colon is narrower than that, meaning the rectosigmoid junction is normally more than one. What happens in Hirschsprung disease is that this rectosigmoid junction becomes less than one. The sigmoid is more dilated than rectum, and what you see is a transition zone. So there is a transition from the narrow rectum to the dilated sigmoid colon. So this is what is very, very important. So the problem here is that the rectum does not have the ganglia. So because there is no peristalsis which is happening here, the sigmoid colon becomes dilated. So actually the part which is dilated is normal. It has the ganglia, but it's the rectum which is narrow, does not have the ganglia. So that's the interesting part here. Alright, this is how we are going to make a diagnosis of Hirschsprung. If you have some diagnostic uncertainty, we can also take a film at 24 hours. If after 24 hours there is retention of barium, that is again something which is a sign that contributes to the diagnosis of Hirschsprung disease. The management is surgical. There are these various pull-through procedures where you resect the aganglionic part and you pull through the rest of the bowel segment. So there are Duhamel's, Suau, Duhamel, Swenson procedures. So these are the different names of the surgeries. So now let's talk about this very interesting case which can be asked to you, as viva questions. So this is microcolon, wherein you see that the entire colon is very, very narrow. So what are the different differentials? Two we have already discussed. One is Hirschsprung disease, which is basically a variant of Hirschsprung wherein you have total colonic aganglionosis. So the entire colon does not have any ganglia, resulting in this completely narrow appearance because there is no peristalsis which is happening here. Another differential here is going to be ileal atresia, right? So when you have jejunal or ileal atresia, what's going to happen is there is no fecal matter, there is no meconium which has ever reached colon, and because of disuse it is narrow. Very, very important third differential is known as meconium ileus. So meconium ileus, something that is associated with cystic fibrosis, right? What you're going to see again, because of the meconium being inspissated and obstructing the intestine, you're going to have dilated small bowel loops, and you can also see these stippled calcifications here, which are nothing but the meconium, right? So this is a very, very important spotter here for meconium ileus, and they can ask you what do you have to rule out, and you're going to say cystic fibrosis, right? So again, one of the differentials for a microcolon appearance. Also, you want to remember that there is an entity known as pseudomeconium ileus. So meconium ileus is something which we will see in normal, term newborns. If you see this sort of an appearance in a preterm, this is actually because of the immature gut. It's because of the immature gut and not really because of the ileus, because of meconium, right? So this condition in preterm is known as pseudomeconium ileus, which frequently resolves on its own. You can also have something which is associated with infants of diabetic mother, which we call as the lazy left colon syndrome or a small left colon syndrome, wherein again you have a motility issue here. So this could be frequently associated with a meconium pellet or a meconium plug syndrome, right? You have a plug which is blocking, and that's the result of microcolon. So these are the different differentials, and if you can answer this, you are gonna again top the exam. So this is what is approach to microcolon. So in summary, acute abdomen is something wherein the clinical features become very important. So you can't just rely on the pediatrician or the clinician to come and tell you that this is what I'm thinking. You need to know for yourself when to keep what differentials. The imaging is crucial. Knowing what imaging is to be done when is again very crucial. And then I have taught you in a clinical scenario manner. So, you know, your differential diagnostic approach should be a combination of both of these. So this is how you're gonna basically approach all cases of acute abdomen in children and infants. So thank you so much, and I hope you enjoyed this.